Alright, so in this video I'm going to discuss low flow oxygen delivery devices, some information about low flow devices, and then the actual devices themselves and how each one of them works. Some key points about low flow devices is that low flow means that it will not meet all of the patient's inspiratory demand or tidal volume. They do not deliver an exact FiO2 because the FiO2 will change based upon the respiratory rate, tidal volume, respiratory pattern, etc. So you have to be extra careful with these devices. Some common devices are the nasal cannula, the non-arm breather, the partial breather, the simple face mask, the transtracheal oxygen catheter, the nasal reservoir, and the pendant reservoir. And I believe these are the only low flow devices that are actually covered on the NBRC exam. A neat trick to estimate the FiO2 delivered by a low flow device is you start at 1 liter, which is 24%, and then you just simply add 4 to each additional liter. So you go from 1 to 2 liters and you just add 4 to 24 and you got 28, and the same thing with 3, you have 32, 4, 38, etc. But keep in mind that this may not be exactly what the patient gets. It's all going to depend on their respiratory rate and tidal volume. Okay, so the first device we're going to talk about is the nasal cannula. Some advantages for the nasal cannula is it is comfortable for the patient. It is very practical in the acute care setting as well as at home. The nasal cannula can support flows up to 6 liters, and the range is like 0.45 liters or 0.25 liters to 6 liters. You always want to use a bubble humidifier if you go above 4 liters. The nasal cannula is probably the most used device. It is what you see your COPD patients with going home, and which really may not be the safest thing, since this is a low flow device, and COPD patients you have to be really careful about their inspired FiO2, but it is the most ergonomical product out there. The next device is the non or partial rebreather mask, and I say it's non or partial rebreather because you can make either one of these masks either a non-rebreather or a partial rebreather simply by taking those exhalation valves on either side of the nose off or on. If you have them on, then it is a non-rebreather, and with them off, it's just a partial rebreather. A non-rebreather is going to deliver about 70% O2 clinically, but theoretically they can deliver 100%, but you're just not going to get that in the clinical setting. The liter flow you do with this is 10 to 15 liters per minute, and the goal here is to keep the bag fully inflated so that the patient, when they inhale, they'll get the O2 in the bag instead of entraining ream-air causing the FiO2 to decrease. The partial breather mask is just really not used in clinical practice, but you may see a question on the NBRC exam because it's on one of the practice tests I've taken. The simple face mask, simply all I can say about it is do not use it. It cannot support flows below 5 liters per minute. If you put a patient on a simple face mask, say at 4 liters per minute, really they're going to get more CO2 than oxygen, and CO2 is a bad thing when you have more of it than oxygen or out of proportion. Really, in clinical practice, I can't think of a good reason to use a simple face mask. I know sometimes post-op, the recovery room will just throw one on a patient, and as soon as they get to the floor, you just need to put a nasal cannula on them or another device of some sort. This next device is the transtracheal catheter. I have never seen this used on a patient, and from what I can read, it's really not used that much. Sometimes in the northern states they use it for patients at home. It can only support 1 to 3 liters per minute, which may be at a disadvantage, or some patients may be on just 1 or 2 liters, but it has to be replaced every 3 months because it will occlude itself with secretions and the patient won't receive any O2, and that would make that a very dangerous situation. So some other things is it does conserve O2 for the patient. because you're bypassing the upper airway, bypassing a lot of dead space, and that may be an advantage to it, but it's just not really commonly used in the clinical setting. These next two devices are the oxygen reservoir systems. The one on your left is called the nasal, it's like the nasal pendant or the nasal reservoir cannula, and then the other one is the pendant reservoir cannula. Simply, the one on the left holds about 20 mils in that cannula on the nose, 20 mils of oxygen, and when the patient inhales, it delivers it all in early inspiration. And then the pendant reservoir works by that cannula will get O2 in it, and when you exhale through your nose, you have to exhale through your nose. It'll inflate that pendant and cause the O2 to rise up to the nose to be ready for inspiration. These devices are to save oxygen. It makes them economically friendly for the patient. Patients tend to prefer the pendant type because of its ability to hide under clothing. Alright, that about wraps up low flow oxygen delivery devices. I will be making another video. The next one I'm going to do is the high flow delivery devices, and I will be making more in the subject of oxygen and medical gas therapy. If you have any questions, my contact information is below, and thanks again for watching.